and welcome to the Nursing Education webinar this afternoon. I hope this is going to be a very interesting session for us all, as we are aware that students went home some time back because of the COVID-19. I think as faculty members or lecturers in our various places, we are struggling, thinking through how learning of our students is going to be. And it's a difficult challenge. Probably we don't have a solution, but this webinar gives us an opportunity to learn from all of you about the things that we've put in place in order to forge ahead despite the pandemic. My name is Abigail Kazembe. I'm an associate professor at Kamuzu College of Nursing, but currently I'm the president for AFREhealth, and I'm delighted to moderate this session. I have a co-moderator, Deborah. She's going to join us shortly. And when she does, she will co-moderate with me. This afternoon, we have planned to share with you 3 sessions. The first speaker comes from University of KwaZulu-Natal, and her name is Olivia Baloyi. Olivia, can you briefly show your face?
All right, I'll do so. Thank you.
You're welcome. Olivia is a professor, and she's an educator, but also she's an advanced midwife. And she'll take us through to look at didactic teaching and learning perspectives of students and faculty. You know, various institutions have put in place different modalities of teaching and learning, and KwaZulu-Natal is one of those universities that has embarked on an online learning. So I would like to hear from her or learn from her their experiences. The next speaker is Judy. I know the flyer says a different speaker, but the next speaker, the third speaker, will join us later. Judy Kanyola comes from Kenya, but is based in Rwanda. And she's going to talk to us about patient interactions. This is what nursing is all about. Now with the COVID-19, what does this mean for the profession? What does this mean for training? So she will share some highlights with us. Finally, we have a third speaker from the registrar's office. We'll show her when she appears. She comes from Kenya. And we are also going to explore the implications from the regulatory point of view. You know, in every institution, the regulatory body will prescribe what students would go through. And basically, we know nursing is a hands-on profession. Now, in the absence of that experience, what does it mean for the regulatory body? Just a few points for us to note. We'll allow everybody to present. The 3 presenters will present, and each one of them will spend some 10 minutes on the presentation. As they are presenting, if we have any observations or questions, let's direct them in the chat box so that we can address them at the end. I would also like to request you, in case we don't manage to address all the questions, you can address the questions to the various speakers. And on our website, AFREhealth website, we have a blog, and we can continue to discuss about those issues. The last thing that I would request you to do is to mute your speakers so that we can hear and understand our speakers very well. With these few words, I would like to invite the first speaker, Olivia Baloyi, to start her presentation. Thank you. I will disappear.
Good afternoon, everyone. Thank you, Prof, for the wonderful introduction, and thanks for having me in this platform. I will be representing the nursing discipline from the University of KwaZulu-Natal in South Africa. And my topic is didactic teaching and learning. And I will specifically be focusing on the perspective of students and faculty. Okay, as part of my introduction, on the 30th of January 2020, WHO declared coronavirus outbreak a global public health emergency. And on the 14th of February 2020, the first case of SARS was reported in Africa, particularly in Egypt. On the 29th of Feb 2020, Nigeria confirmed its first case in the sub-Saharan Africa. This was followed by the WHO declaring COVID-19 a pandemic on the 11th of March 2020. On the 5th of March 2020, South Africa reported its first case, and that was in the province of KwaZulu-Natal, where the university is based. This was followed by the national lockdown, which was declared by the South African government in response to the pandemic on the 26th of March. With the lockdown, all the universities in the country were closed, all the schools, like the only people who were allowed to go to work were those who were rendering essential services. Then all the countries in Africa were affected and infected by this pandemic. South Africa started well at the beginning, where we had lesser cases, but today South Africa is having more cases in South Africa. In Africa, I think it's the 5th in the world as of the 18th of August 2020. Then this national lockdown, which was declared by the South African government, put nursing education into a life support. Nursing education came to a standstill during that period. Then the South African Nursing Council, which is our regulatory body, which governs both the nurses and the midwives, released a circular on the 25th of March 2020. The circular had an impact on coronavirus outbreak on nursing education and training, to provide supportive guidance to the nursing education institution in management of interrupted education activities during the pandemic. Then the circular encouraged institutions to examine alternate means of imparting nursing education. Because according to the South African Nursing Council, yes, the country was on a lockdown, but they still saw it important that our students still need to be taught. And they strongly encouraged that not to compromise the student education. All right. So following this circular from the Nursing Council, the University of KwaZulu-Natal Teaching and Learning had to sit down together with different disciplines, nursing being one of those disciplines, to plan on the way forward. The plan was to continue providing nursing education and to inform the revision of module guides and templates. We had to sit as a discipline and revise our module templates as well as our module guides, because everything in our module templates and module guides was for face-to-face contact. And because of the pandemic and the lockdown, we were unable to provide that face-to-face contact. Hence, the revision of the module guides and the templates. Our lecturers were not prepared for this. Hence, the university saw it fit to capacitate the lecturers on the following. The lecturers were capacitated on innovative teaching methods, on online teaching assessments, as well as identifying vulnerable students. So the lecturers undergone online trainings which were offered by the university in order to prepare them on how to render online teaching as well as online assessments. And we also had to identify the vulnerable students, because some of our students, like mainly of our students, come from the rural settings. So we had to ensure that we identify those students who did not have the relevant resources for when we start online education. Then the students were not left. Teaching and Learning from University of KwaZulu-Natal also had to equip the students in order for them to receive free data, because the students, they were used to using the Wi-Fi in the university. So we had to make sure that they get free data in their mobile devices or in their laptops in order for them to be able to engage with online learning. And those students who did not have any form of devices, they were offered those devices by the university. Majority of the students did not own any laptop because they were used to using the university lens. Then the university provided those students with devices such as laptops. The outcome was that we had to continue with online teaching until the students return on campus. The perspective of the students. Our students were affected psychologically. They were frustrated by the home demands, which were overshadowing their learning opportunities. Some of their parents did not understand the fact that they still had to do their online learning. The parents expected them to wake up in the morning and continue with the house chores, do the cookings and everything. So it was frustrating them, as they had to be in class sometimes at 8 o'clock, and the mother expect them to go to the river to do the washing. They were very anxious. They wanted to return to campus where there is access of resources, and then where they can do their studies without any disturbances. Social perspectives, this varied from family levels of support. Some of the students, their parents lost their jobs because of the lockdown. So they were affected by that. There was limited financial access to buy more data when the university data is finished. Then we had the theory and equal opportunities. Yes, we were doing the online teaching, but not all our students had access to that, despite the university offering them devices as well as free data. Some of the students, they could not still access because of, you know, the geographical area where they were based. Network was a problem. Then the other was the clinical. Our students were very worried about their clinicals. These were some of their direct codes to express their frustration about clinical. Will we be known as the group with theory and no practice? They were very worried that they will graduate and they will only be having a lot of theory and no practice. And they felt that they want to be doing something useful and be assisting during the pandemic. Perspective of the lecturers. The lecturers also experienced some psychological impacts. They were overwhelmed. There was increased demand in terms of the work. They had to review the templates. There were a lot of changes which were expected of them from the university. There was some level of frustration because at some point there was lack of clear directives and reasonable requests in limited time. They became irritated in the process because of the repetition of activities. They felt helpless because of not being able to provide students with the answers. We were like the first contact of the students. If they had queries, they contacted us. Then there was an increased level of fear because of, you know, those who had comorbidities and those who were above the age of 60. They were very worried as to what is going to happen when the students go back on the clinical platform and they have to support them for clinical accompaniment. Self-efficacy, when they learned e-learning navigations, they also became frustrated because it was something new that they had to do on a full-time basis. Then socially, there was limited respect of time boundaries. We did not have the time to start work and the time to go off. Sometimes the DVC will request some submissions, you know, at 10 o'clock at night, and that needed to be done. We had to adjust to new ways of interacting as colleagues. You know, we could not move from office to office, but we had to learn, you know, ways of interacting via Zoom meetings, via Google Meet, and so forth. And it was very difficult to access people through the unusual means, because some of our staff members, they are also coming from remote areas with limited access to network. There was increased access of students, especially working master students. This was particularly for our postgrad students who are registered nurses and midwives and are working as frontline workers. We had to make sure that we see these students at night or have Saturday classes with them. Theory, opportunity for creativity in a presentation, and there was a lesser sense of satisfaction that the student grasped the content, the concepts, because we could not see our students face to face. We could not see if the students were following the teaching. And it was very challenging to engage the students. Sometimes we'll try to engage the students and they will be quiet. You know, they will be silent with their mics on mute and nobody will be saying anything. It was really challenging and frustrating. And also the challenge that I've mentioned of the frontline master students who can't attend because of erratic shifts and as well as feeling exhausted. Clinical, a challenge to teach the skills. It was very challenging for us to teach the skills because, like Prof mentioned, that nursing is a hands-on profession. And we're also very concerned about the possibility of the students being able to complete their clinical hours. Then there was a point when nursing had to go off the life support. This is when the Minister of Higher Education announced the return of the university students, the phased-in return of the students. With that announcement from the Minister, there was a lot of confusion as well. We didn't know where we are going and which route are we taking, but life had to go on. Okay, so we had a process which was like the phased-in approach. Then the university announced the phased-in approaches beginning with the final year. With nursing and our fourth year were part of those students who were to return to the campus because they were final year students and they had to do their clinical and complete so that they can start working next year. And the university had to provide the student with PPE as well as sanitizers because the hospitals were not going to provide for that. Then we also had to observe the IPC principles and ensure PPE competencies. We had to train our students on PPEs and we had to make sure that they are competent before they could go to the clinical facilities. Our students had to write an online test to that and they had to obtain a mark of 80% for them to be declared competent to return to the clinical facilities. The challenges. We experienced increased exposure of risk of exposure and infection. There were students who were left behind because some of those students never managed to connect online at all. And the challenge of the student having to meet the regulatory body requirements for the clinical hours. And we had some of our students who tested positive for COVID, and these students had to be on isolation, and this led to another loss of time. The students themselves, they were in fear because they were afraid that they will infect their family members, especially those who are staying with the vulnerable population, those with comorbidities, and those with like the elderly. They were not comfortable at all going to the clinical facilities. And we also experienced a shortage of PPEs from the hospital, and the university had to provide the students. However, I've just mentioned the challenges that we experienced, but these were not only the challenges. You know, we have learned something new as the nursing education institution, particularly at University of KwaZulu-Natal, based on what we experienced because of the pandemic. We learned that the whole situation created an opportunity for the nursing education institutions to fully embrace technology-based learning. Like all of us now in our university, we are saying that, you know what, nothing in future will stop us from learning because we have learned so much, and the fact that we can use technology to still deliver the content. Diversity or investing resources to e-learning, which was in some cases not viewed as a priority. So for now, I think our university have learned that it is very important for all the students and for all the staff members to have mobile devices for times like this that we have just experienced in terms of the COVID and the lockdown. Strengthening the capacity of nurse educators in technology and driven teaching and assessment. Our teaching and assessment was so face-to-face and so book-based. Now we have learned that even after the pandemic, as we are teaching our students, we will be able to bring in technology in it. Like now I am capable of conducting a clinical session with the students online. I don't have to be going to the clinical facilities all the time. And this will be carried over even after the pandemic when life goes back to normal. Regarding the clinical, this experience of the lockdown and the pandemic forces nursing education institutions and regulatory bodies to revisit the dialogue about the covering of clinical hours versus the mastering of the required competences. Like now, are we still looking into our students covering the 1,000 midwifery hours as required by the South African Nursing Council? Or in future, can we now start looking into our students mastering the competencies rather than, you know, being glued on the fact that the students need to cover the required clinical hours? Then these were the resources that I have consulted, and then this brings me to the end of my presentation, and thank you very much. And I apologize if maybe I've passed my time limit. Thank you.
Thank you so much, Olivia. Let me quickly introduce to you my co-moderator, Deborah Zinkanajo. I hope I pronounce your name well. Can you just show your picture briefly so that people know you?
All right, not a problem.
Can you Deborah, see the speaker?
Is it? Oh, sorry. Okay.
The moderator. Are you there, Deborah?
I am. Excuse me, I was having trouble with my camera. Thank you. That was a fantastic presentation, and I'm looking forward to the next one as well. But it's a real pleasure and honor to join you for this webinar. Thank you.
Thank you, Deborah.
Thank you
so much.
And I also want to introduce Gladys Matura, sitting in for Registrar Kenya. Gladys, if you are there, can you just flash your face so that people see you?
Good evening. I'm actually on the road.
Okay.
I don't know if I can be seen. I'm doing some work out in the field. Let me remove my mask briefly. Yes, that's Gladys.
Okay. Thank you so much for taking up the task on behalf of the registrar. And now we'll hear from Judy, and you'll be the last one to present. I now call upon Judith Kanyola.
Thank you so much, Abigail. Good afternoon, good morning, everybody. And thank you so much for taking the time to take part in this webinar. I'm learning how to share my screen. Can you see it? Oh dear.
Not yet. Not yet, Judy.
Share screen. Is it coming?
Yes.
It is coming.
Yes.
Great.
Yeah.
Let me now go to slideshow and start the presentation. So once again, good morning, good afternoon, everybody. I'm going to talk a little bit about navigating patient interactions as we discuss some of the conundrums for nursing and midwifery education in this era of COVID-19. My name, as Abigail has said correctly, is Judy Hanyola. I'm just the newly appointed chair for the Center for Nursing and Midwifery at the University of Global Health Equity in Rwanda. Role I just took up right at the cusp of COVID in February this year. And I'll just talk very high level about some of the challenges that COVID has brought to the profession of nursing and midwifery, and perhaps some of the recommendations or some of the things we could think about to begin to solve these conundrums. It's a huge topic. 10 minutes really won't allow me to do justice. So I will just speak from a very high level, thought-provoking perspective around this. This is a quotation that came from a husband of a nurse who died in Kenya 2 weeks ago. The nurse works in one of the counties in Kenya, in the western part of Kenya. She died in childbirth because of COVID-19. And this gentleman said, I do not want any other person to go through what we have been subjected to. Patients deserve care, and their kin deserve to be treated with dignity. I got this from the Daily Nation, which is one of our daily newspapers here in Kenya. And this man, when I read this, I just said, it's very important as we look at COVID-19 and as health workers, and specifically as nurses and midwives, to remember that at the core of what we do is a patient. At the core of what we do is a human being. And if at the end of any interaction that I have with my patient, this is what they will say, then to me, I believe as a profession, we have failed, and we have failed miserably. Some of the 21st century health challenges we have, which are known to most of you probably much more than even I know, is we have a lot of gaps and inequities in health, both within and between countries. We have a gap between the global north and the global south. We have a gap even within the global south. And even within individual countries, we have a gap between urban and rural, between rich and poor, between educated and not educated, between men and women. And these gaps fuel a lot of the health challenges we face in this 21st century. We have been unable to share health advances equitably. This has really been brought to the forefront by Corona. Even in countries, richer countries than us here in Africa, we have seen this come very much to the front. We are facing fresh health challenges. Right now, we're talking about Corona, COVID-19. We have environmental risks, we have behavioral risks, we have demographic and epidemiological transitions. And all of this has resulted in our health system struggling to keep up. And all of these are exacerbated by the complexities and the costs around that. So what does this translate to? It means that there are huge demands placed on health workers, particularly nurses, particularly here in Africa, where often nurses are the only point of care into the health system in many of our rural areas. And professional education has not kept pace with this challenge. One of the questions and one of the things, you know, through my work and through my experiences, we have fragmented, outdated curricula that then produces ill-equipped graduates. And I'm very happy to hear Olivia talking about the challenges they are facing in South Africa, not so much the challenges, but really that their eyes are opened, that their minds are opening up to see how they can change a lot of these things, many of which has been brought about as a result of the coronavirus. We have systemic problems in health professional education, especially with us as nursing. We have mismatch of competencies between patient and population needs. So when I went to nursing school, we were a very medicalized model of teaching, where you're taught about a disease and how to manage that disease. And then when you come out into the real world and begin to interact with patients, with communities, with populations, you realize that there's a big gap between what you learned in class and what the populations and the patients need. We have very poor teamwork. And one of the things that I'm very happy about AFREhealth is that it's beginning to change this mindset, this paradigm, to begin to see us working together. We have a persistent gender stratification, especially in nursing, which is predominantly female, which then means that nurses are often seen, especially in the African perspective, which is very patriarchal, as lesser. And this stratification also means that it denotes the profession in a certain way. Then also, like I mentioned earlier, very narrow technical focus in our curriculum, in our teaching, without broader contextual understanding. So for example, when you are in class and you're teaching about, we are looking at COVID. So for example, respiratory infections, we really just focus on the medical side of it, and we don't really understand, for example, what are the community or the contextual reasons that would result in, for example, populations having recurrent, respiratory infections. We have episodic encounters rather than continuous care, again, as a result of our, inheriting a very traditional, colonial way of teaching. And so patients come to us, we see them, they go away, we don't really talk anything more than that. Then we see them again, we even don't have a way of seamlessly understanding what happened between encounter number 1 and encounter number 2. And this then also, of course, results in systemic problems. We have a predominantly hospital orientation at the expense, in my view, of primary health, especially here in Africa. I see even here in Kenya, we just have so much focus on building more and more health centers, thinking that this is the solution, which I've often found 60 years after independence, if we continue building more brick and mortar, I don't really see that this is going to be the solution to our problems, especially in light of Corona now, and we are being told to keep our distances from each other. Quantitative and qualitative imbalances in the professional market. So we have factors that drive so much training of nurses, so much training of midwives, so many schools of nursing, so many schools of midwifery. When these graduates come out, they don't get jobs. They are not employed. And I say, what a waste of a nurse and a midwife in Africa, that this nurse and midwife cannot be gainfully employed at a time such as this. Very weak leadership. What I want to call the tribalism of the professionals, the tendency of the various professions to act in isolation from, and sometimes even in competition with each other. What has this current coronavirus pandemic revealed? Well, for me, definitely it has revealed a failure of the public health system. It's such a glaring failure. It is so sad, and a scathing indictment of us in the health sector, that all our weaknesses have been exposed by this tiny virus, to show that really we were just teetering on the brink. Complete lack of trust between the populations and the health systems. And what I know in Kenya, because at around this time, 4 o'clock, the Minister of Health stands somewhere and gives a reading of so many cases today, so many people have died, so many people have recovered. And I always feel that he's talking at people and never really talking to people and trying to understand. In Kenya, for example, a mask at the beginning of the pandemic was costing upwards of $10 for somebody who earns $1 a day. What does that mean for that person to be forced to wear a mask without understanding why? And having the police, even when they started putting in things like their lockdowns and their curfews, beating people simply because they were trying to make a living, without really trying their level best to understand the populations, to help them. This lack of trust between the populations and the health system, I think, has also been really revealed as a result of this corona. Massive corruption. I don't know about you, Abigail. I don't know about you, Elsie, in Uganda, Abigail in Malawi, Olivia in South Africa. But here in Kenya, we have had a tremendous, theft of COVID funds, a lot of donations from the Global South. Jack Ma sent us so many tins and barrels of PPEs, and just to hear that one person has taken them in a go down and turned around and then sold the very things that were given to us as donations back to the Ministry of Health, who then buy it at like 4, 5, or 12 times the price. this is just so sad. You know, neglect by governments of their populations. I know in July 6th, when the president of Kenya said, okay, we have opened, people can move freely, he actually said, you know, it's up to you. Take care of yourself. If you don't wash your hands, if you don't wear a mask, and really know again, like I keep saying, understanding of what people really face in their day-to-day lives. We have a non-existence of surveillance to detect health threats. So, you know, things like Corona just come on us and, you know, bring us down. And like I've said before, very poor leadership. We need to recenter care and service provision. And I think this is so important for nursing and midwifery education, because then we need to go back to the drawing board. I always say we need to go back to the ethos of what nursing really is. As nurses, one of the things that made me get into the profession was the fact that I could be with the patient and interact with the patient for a prolonged period of time, help the patient through their journey of sickness or illness or not feeling well. And so when we now move away from the center of nursing and service provision to things like looking just at computers, not looking at patients, not talking to patients, not empathizing, not sympathizing, not being compassionate, these challenges come back to bite us. We need, I think, very critically to recognize the importance of primary health care. In Africa, where we even lack resources or have limited resources or lesser resources, so to speak, I think the importance of primary health care comes to the fore. It's not easy for somebody like my grandmother in the village to access a tertiary institution where she's going to see the likes of Professor XYZ in his you know, fancy clinic. And so we really need to recognize that primary health care is important for us here in Africa. We need to strengthen our scientific education and stop making it so medicalized and make it more around what are the reasons for what you know, for the conditions or the challenges that people face in health. We need to integrate classroom and clinical teaching. Olivia, my colleague, alluded to this in her presentation. Of course, nursing is a very hands-on profession. It's a labor-intensive profession. It requires touch. It requires, you know, actual face-to-face. It requires privacy. It requires entering into somebody's private space. And as a result of this, how does the what we teach in class and what we see in the clinic integrate? Important for us to identify, and this is coming more and more, even here in Africa, in our nursing and midwifery school, what are the core competencies we want to see in nursing, in nurses, in midwives? And then what are the skills and support systems that we can then put in place for nursing? And then devise our curricula to adapt to our local African context. What is the issue here in Nairobi, Kenya, for example? What is the issue in Malawi? What is the issue in Kampala, Uganda, for that matter? Or in KwaZulu-Natal in South Africa? They are not all the same, and our curricula needs to be adapted to our local African context so that then we are responding to patient needs. This is a clip I got off one of my readings. It's talking about transformational learning, and it's telling us that we have to move away from the old things in old ways, move up from old things in new ways, and move to new things in new ways. And then even evaluate these new things. Are they working? We need to look at, have a vision, we need to have leadership, and we need to look at the community, especially here in Africa. It's very, very important. Many of us come from very communal communities. We are less individualized like the global north, more of the community. Understand that people come from a village, if I can say, and the way they say it takes a village to raise a child. What are the issues within the community? We need to be able then to be creative, to be mobile, to collaborate, to differentiate, all of this together leading to transformational learning. If we do the old things in the old ways, it's not going to help us. Corona has clearly exposed these 21st century issues. E-learning, Olivia mentioned that. We have to go back now and begin to robustly strengthen our e-learning, look at digital education and connectivity. One of the things I'm seeing that has become very important as a result of Corona has been the need for internet, for access. And now we have to talk to the mobile telephone community, you know, like Safaricom here in Kenya or MTN. how can they help us then to make sure that we are teaching, especially our health workers, in a creative way, in a way that is allowing the competencies to be learned. We need to then, as a result, redesign our nursing and midwifery education. Nursing and midwifery education in Africa should focus away from rote learning, from memorizing, to critical reasoning and ethical conduct. I always find that as a nurse, I think ethical conduct is even more important than even the science or the information that I have in my head. Am I conducting myself ethically? When I go back to the quote of this man who lost his wife, a nurse in Kenya, as a result of COVID, there was a lot of unethical conduct there from us, very, the very health workers who are there to help at the point of need. It should ensure that graduates are competent health systems. And here I want to go back to the core of nursing, strength-based nursing, where we're not looking at what problems do patients face or families face, but rather turn it to say, what are the capacities, competencies, and skills that families have? And when we look at this, then we begin to help the communities, the health needs in our communities, to devise their own solutions to their own problems in a way that is meaningful to them, rather than top down, where we are saying, oh, you have a problem and this is how it should be solved. And at the end of the day, then our nursing and midwifery education should produce locally responsive but globally connected teams. This, of course, will then in turn assure a universal coverage of essential, high quality, comprehensive services for our people. What should we do to then ensure these quality patient interactions? Like I said earlier, we need to integrate primary healthcare training into the overall academic system. In Rwanda, they have done this very well because they've recognized, due to the ruralness of the population, the lack of, maybe let me say, lower financial resources of the country itself, looking at tertiary, overly medicalized, extremely high-tech solutions do not work if we don't first look at the primary healthcare and begin from the beginning. So we really need to make sure that as we are training our nurses and midwives, we're integrating primary healthcare into our academic system and not really focusing on highly specialized, medicalized at the expense of general primary healthcare. Provide a balanced environment for educating nurses through engagement of communities. One of the key things about being a nurse and a midwife is that we live and work in the communities and practice in the communities within which our people live. And so through there, we can address prevention issues. We can anticipate health threats. If I live in the community, I'm able to see what are the climate issues that can affect my community and anticipate this. As a result of this particular climate issue, for example, flooding or mudslides, we then anticipate XYZ health threat. As a result of living close to factories or close to a water body, this is the health threat that would come, and thus preempt a lot of the challenges. And then, of course, lead in the overall design of the health system. One thing I think that would be really good to make sure our patient interactions are quality is twinning. This is a very good thing for the global north and the global south, where we have institutions, and through MEPI, precursor to AFREhealth today, there was a lot of twinning that happened between institutions. For example, here in Kenya, we have Moi University, which twinned, I think, with Indiana University and the AMPATH programs. We have a lot of schools of nursing within Africa, which have twinned with some of the schools in the global north. And this has allowed for robust, or what can I say, what's the word? I want to say not expensive way of developing the capacity. And when, for example, we have short-term, faculty or health workers, nurses and midwives from the global north involved in the delivery or as partners in the delivery of health services, we're able then to lift out some of the things in the global south that we face, for example, shortages in faculty, and quickly begin to build capacity.
Judy, I'll have to interrupt
use
you.
of IT, I have. 2 minutes.
Wrap up.
Yes, I'm finishing. Use of IT is, of course, goes without say, and we've seen this coming more and more to the forefront as a result of Corona. Capacity strengthening to increase qualified teachers. I talked about twinning, which is one aspect we can do to increase qualified teachers, which are very scarce here in Africa. And then last but not least, instructional design. And here I'm doing these 3 C's. We need the criteria for admission. Not everybody can be a nurse. Not everybody can be a midwife. Not everybody can be a doctor. Not everybody can be a pharmacist. What's our criteria for admission? What are the competencies we want to see in our nurses and midwives? What are the channels through which we are going to teach? Team-based learning, less of the didactic models, and what are the career pathways then for these nurses and midwives? I want to end here by reading, oh dear, I've gone back, should I? Quotation from Louis Menand: the pursuit, production, dissemination, preservation of knowledge are the, are the essential activities of a civilization. Knowledge is crucial, it's a social memory, a connection to the past, and it is a social hope, an investment in the future. The ability to create knowledge and put it to use is the adaptive characteristic of humans. It is how we respond, we reproduce ourselves as souls, as social beings, and how we change, how we keep or let our feet on the ground and our heads in the clouds. Thank you very much for listening to me.
Thank you so much, Judy. I now call upon Gladys Matura. Gladys, can you hear us?
Yes, I can hear you.
Thank you. It's your turn.
Thank you very much. Just give me some few minutes.
Sure.
Okay, so I'll briefly take you through okay. So regarding the COVID-19 pandemic, as far as education for nursing and midwifery is concerned in the country, briefly, in December 2019, the world woke up to the pandemic. That is the corona disease. The pandemic spread fast in all continents of the world, and Africa recorded its first case as well in Nigeria. Then on 13th of March, Kenya joined the list with COVID-19 cases, where we recorded the first case. And since then, the cases have been on the rise in the country as well as globally. So as at the time of writing the presentation, Kenya had recorded approximately 30,636 cases, which have been reported with around 487 deaths. So the number is projected to rise, although in the recent past, the curve is seen to be flattening. Regarding teaching and learning during this pandemic, the government of Kenya, like many other countries, has implemented measures to flatten the curve of the coronavirus pandemic. The measure basically aimed at reducing the number of new COVID-19 cases on a daily basis. And this therefore included restrictions of movement, as well as closure of training institutions at all levels, among other measures. Currently, discussions are still ongoing on how to open up the education sector. However, many documents, protocols have been developed, and this is to address teaching and learning, particularly in the tertiary institutions. So approximately 70% of nursing and midwifery training institutions in Kenya were offering, prior to the pandemic, were offering face-to-face training, while the rest were offering a blended mode, that is face-to-face as well as online. So this has necessitated rapid change from face-to-face to online. So considerations regarding teaching and learning. On the aspect of admission of students and orientation to nursing and midwifery training institutions, The face-to-face institutions were also forced to embrace online and therefore admit students online, which include also virtual orientation. Then student management, monitoring and evaluation during training. As a council, we oversee the management of students into the training institutions. This has to do with the course they undertake, the assessment. And so in the event of any disruption that may require a student to be out of school for a while, we expect training institutions to report. And so previously this was being done manually, but now revisions have been done to facilitate online. Regarding theoretical teaching, major impact on this was schools that were majorly face-to-face. They were forced to move to online, to adopt online teaching and identify platforms that would support them to facilitate the same. Regarding formative and summative assessments, we also at different levels on this. There are institutions that have managed to effectively assess their students, both formative and summative, and there are some that are also working on the same, especially in consideration of the online aspect. So investments in systems required to support online teaching. This is also an impact that institutions are facing currently. For those that had blended mode, they seem to have been able to move the face-to-face into their platform, but for the institutions that were purely face-to-face were actually forced, and even some are still working on that, to invest on online teaching. Regarding faculty, there was also need for preparation of faculty members so that they're in a position to manage online teaching. And therefore, this required some training to equip them with skills and also to assist them to now embrace online teaching as effective mode of delivery. And even to the learners, it required a paradigm shift because majority of the learners in the nursing and midwifery training institutions were quite familiar with the face-to-face environment. And therefore, it required them to now view and also be active as long as online learning is concerned. Regarding licensure examination, we had scheduled licensure examination in April. This is around 2 weeks after the announcement of the first case. And so what happened is that there was disruption since our examination were being offered manually, and so we had to put that on hold, especially following the restriction of movements. And so as a council, there was exploration of administration of licensure examinations online. So this is what we are working on so that we're able to administer this year's licensure examinations online. And so what this meant is that as a council, we needed to review business processes to see how these would be supported. Actually, this is the activity I'm doing. That's why you are seeing I'm in the field. Then regarding clinical experience, there was also some disruptions in this area. So clinical placement and teaching was put on hold until such a time when they can be implemented effectively. So on these, discussions are ongoing to see how students can be accommodated. Practical assessments, there are assessments that are prescribed by the council, the training institutions, that are mandatory. So besides what training institutions may add, they are expected to comply with what the council prescribes as major nursing practical assessments. And so these two have been put on hold. There was also need to develop and evaluate protocols for students on clinical practice, and then limited PPEs. So discussions are ongoing, especially regarding C and D, where we will need to develop protocols, then we'll need to discuss regarding the support that students will require. And the discussions are around PPEs. Will the students be provided for by training institutions, or are hospitals in a position to support the students? There are also a few concerns. Should a student be in the clinical area and probably gets infected while doing their clinical practice, how would that be handled? Is there a medical cover? So those are some of the discussions that are ongoing. Thank you very much.
Thank you, Gladys. You've kept the time. I now hand over to Deborah to address any questions if there are any.
Thank you, Abigail, and thank you again to all of our presenters. It's been a really interesting round of experiences to catch up on. And if I could encourage anyone who has questions for our speakers, please do go ahead and put them in the chat box. We have a few minutes, and we want to be sure that we capture issues that you would like to put forward. But let me just again thank you, each one, starting I think with Olivia. You did a masterful job of presenting both the perspectives of the students, the learners, and also from the faculty. Really a well thought out way to look at the issues going from with the restrictions in place, both around looking at continued learning as well as the needs of students as they return to clinical practice, both of which have to be forefront in our minds. And Judy, you've called us to rethink and recenter nursing education and practice, refocus back on both the skills and competencies, and also rebuilding the trust with populations by listening to their strengths, to their needs, and reorienting how we think about the training that is offered. And we are very much with you in Kenya in terms of your working through the processes around licensure, how you do the practical assessments, how you administer things online. So this is very much a learning. We will learn with you, as we've learned from the South African Nursing Council as well, how these issues are being taken forward. So again, I don't see any questions, so we'll close this for now, but our thanks again to AFREhealth Secretariat for making this possible. Very much appreciate all the work that you've done, and we look forward and hope that you will continue to join in future webinars on nursing practice and education. So with that, we thank you very much. Thank you so much, and have a good day.
Thank you.
Thank you, everybody. Thank you so much.
Thank you, everyone.
Thank you, everyone. Thank you so much.
Thank you.
Check out the presentation on the AFREhealth website. Bye-bye.
All right. Thanks so
I
much.
hope you're sharing the slides if you're willing. Thank you.
Thank you. Thank you.
Bye.